cardiac medications instead of hypnotics. Just, you know, super quick. So, all right, well, welcome everyone. I will try to share my screen. Again, this is going to be, you know, a little bit of a whirlwind. It's going to be top level stuff. Try to identify the things that might come up in questions. I will open the chat, so please throw questions up there, whether they are clinical or for the test. Let's see if I share well. All right, antidepressants is first. Okay. Nope. All right. Can you see? It should, title slide should say antidepressants. Okay. Fantastic. All right. So, and I apologize. The times that we have written down for today's lectures may be a little flexible. We may have to flex up and flex down on some of these topics, but that is fine with me. And if we go over because of questions, that is great as well. So this is the group of antidepressants that are in the CSPI test for content. So I will briefly go over all of these. Put another way, a very, very long list of antidepressants. You can roughly group them a couple of different ways, you know, the TCAs and then SSRIs and SNRIs, and then you get into those like, what is bupropion? It's sort of SNRI-ish, but it's not really an SNRI. So you can some just simply group them into, you know, non-cyclic drugs, and you can kind of see the toxicities here a little different. The older tricyclics, you know, antimuscarinic, hypotension, QRS widening, seizures. All of you are familiar with that. And the newer ones, much more in the seizures and serotonin syndrome world. But I think you can group most of them together. Most antidepressants affect serotonin reuptake in some way, whether they are selective or not. That is generally accepted as the antidepressant effect, but there also seems to be an added antidepressant effect with increasing norepinephrine concentrations, and hence the SNRIs. You know, the older ones, the tricyclics, were kind of found by accident and have many effects that are mostly unwanted. Only a few are wanted. Most of these are going to potentially lead to serotonin toxicity and sedation and overdose, and those with norepi effects. I would add in tachycardia, agitation, tremor, seizure. So let's just go to the specifics. Tricyclic antidepressants, they've got this chemical structure that's 3 cyclic structures. Surprise, surprise. They tend to be very, very rapid onset, and I know some of you with a bit more experience have seen a bazillion of these, and some of you with not a huge amount of experience may not have seen a huge amount because we just don't see them as much anymore. But they are very rapid in onset and overdose with altered mental status, and then a very, very long list of things that can happen. Antimuscarinics and the antimuscarinic toxidrome. Seizures likely from GABA inhibition, hypotension. I just remembered to open the chat. Sorry, let me do that while but I apparently cannot do more than one thing at once. So, all right. And then hypotension is specifically from alpha antagonism, and that will become a factor when we start talking about how we treat it. And I do think that that could potentially be a specific question, since it's a specific receptor effect. And then QRS prolongation and QTC prolongation from sodium and potassium channel antagonism, respectively. So what do we do? How do we treat this? Okay, so QRS widening. QRS widening is from blockade of sodium channels. I think that the answer to any question on the test is what is a wide QRS that is greater than 100 milliseconds. I know we just had this conversation at the retreat about using 120, and I do think that that's a better use of our resources and not over treating people. But I think that the answer on the test is, who gets treatment for QRS widening is probably 100 milliseconds. Honestly, my guess is that they can't have that question because it's a little controversial and there's not one right answer. But the other aspect of the EKG that is an indication for treatment with bicarbonate is an R in AVR. I'll show you a picture of that in just a second. That R should be more than 3 millimeters high, which is 3 boxes, and at least 1 box wide. And the reason for that is because there are some pediatric EKGs that have this little spike that's extremely narrow that does not count as QRS widening an R. It doesn't count as an R. So both of these correlate with seizures and with ventricular dysrhythmias and with toxicity in general, a sort of a dose-dependent effect on the QRS. And as we mentioned in the retreat, a QRS over 160 has a 50% risk of ventricular dysrhythmias, so be afraid of that. So here's a kind of a classic EKG. Heart rate is about 130, I think. You see these really, really wide QRS here. It's wide everywhere. This R in AVR is 3 boxes. You would measure it. This is kind of a hard one, actually. You certainly measure it from here, but maybe even here was probably the baseline. So it's 3 boxes high and at least 1 box wide. It is much larger than that. So this is sort of a classic TCA. EKG is another one. Again, I think the heart rate's a little faster on this, 140. QRS is 480 or something. No, I'm sorry. I got my numbers wrong there. What is the QRS here? That's probably 600. No, sorry. I'm doing this. I apologize. I was just thinking about the QTC. This is, yeah, it's probably about 200. And then the R and AVR is huge here. It's big and it's really, really wide. Yeah, why the AVR? So what's happening with these is I don't have a great explanation except that it just happens. Sodium channel blockade is more potent on the right bundle than it is on the left. I think it probably has something to do with the density of sodium channels and that it's easier to significantly block more sodium channels on the right side. But I have never found a explanation that is satisfying. So what we're actually seeing is, let me stop for a second. What we're actually seeing is that, the QRS is the left and the right bundle just sitting on top of each other. They normally conduct electricity at the exact same time, so it just looks like a big spike. But what we're actually seeing is that the right bundle is slowing more than the left bundle, and so we have a normal left bundle and then a right. And so the R and AVR is really, it's kind of like a sign of an incomplete right bundle branch block, and so that's why we're getting this weird we're getting this weird shape. And I think one of the things that is characteristic of a TCA EKG is a sort of bump on the QRS here. You can kind of see here it changes, and that's because you've got two. You can see this little wedge here, and here it's where it goes right there, and then it changes again. And that is because you're getting those 2 bundles that are kind of overlapping a little bit, and you can kind of see it in the AVR here. Like this feels like it should come right down to here, but it's not. It's got this other slower bundle and same with here, right here, right? It feels like it should just keep going up, but it doesn't. It slows down. So I don't know if that helps or not, or if that makes any sense. Okay. Yeah, and so the AVR is just the one that picks it up, and it's also the one that doesn't get affected by a lot of other things. And so there's been some pretty good studies that looked at AVR. If there's an AVR if you've taken a tricyclic antidepressant and there's an AVR, an R and AVR, then it has the same predictive value for seizures and ventricular dysrhythmias as a QRS greater than 100. So I think it's just another sign of toxicity. I know we had a case not that long ago where a person had an R and AVR, but like a normal QRS and no other signs at all. I think some people just have abnormal EKG sometimes, so I don't have a great explanation for that. All right, treatment, I think you probably mostly know, but let's review it. Activated charcoal, if they get there really early, these are in overdose very, very rapid in onset. So most of the time we will not have the opportunity to give them charcoal because they will, have a seizure in the first hour or have CNS depression. But, supportive care. One thing that I would, that you might get a question on is the hypotension. Obviously, you give fluids first, but because it's a tricyclic antidepressants are an alpha antagonist, there are some that, and I think it's a reasonable argument that would start an alpha agent to treat them specifically. So something like norepinephrine or phenylephrine, usually phenylephrine because their heart rate's already 160, and if you give them norepi, their heart rate will go up even more. So I think that in this specific case, the answer would be phenylephrine. You can also make an argument for vasopressin because it has a totally different mechanism, but more so than epi or norepi because they're more likely to start to worsen the tachycardia. QT prolongation, as we have talked about many times before, there is no therapy for drug-induced QT prolongation. So what we do is we try to correct any other effect on the QT that we can. And the most common with our patients is low calcium, potassium, and magnesium. So I think the key point is giving someone mag, calcium, and potassium and repleting them doesn't fix their drug-induced long QT, but it may shorten their QT because they also had hypocalcemia, hypokalemia, or hypomagnesemia. And then ventricular dysrhythmias, there probably is an answer here. Lidocaine is probably the drug of choice for the ventricular dysrhythmias over amiodarone. Lidocaine seems a little weird because lidocaine is a sodium channel blocker, but it is very, very fast on and fast off, and so it competes with the tricyclic antidepressant, and it can decrease its effect. So not only can it treat the ventricular dysrhythmia, but if we are wrong, and we are often wrong because it's really hard to tell the difference between VTAC and someone with a heart rate of 180 with a QRS of 240. I don't have a great way to do that. So lidocaine will actually narrow the QRS as well. So even if we're wrong that it's a ventricular dysrhythmia, that still can work. So that doesn't change the fact that bicarb is the first line. There's no question about that. If the QRS is wide, we give sodium bicarbonate in boluses. But if you're thinking it's a dysrhythmia, I would start with lidocaine. And then tricyclic antidepressants should respond to IV lipid emulsion. There's certainly no randomized controlled trial to tell me that, but it does seem like a reasonable thing to do. So I think that's one of the biggest things that's probably changed in the last, 10, 15 years. So I was mentioning QRS prolongation. I like to think about QRS prolongation. It's a blockade of sodium channels. The voltage hits a certain voltage, the sodium channels open, sodium rushes in the cell. That's the beginning of the QRS. if you have a lot of sodium channels blocked, then sodium will get through because it only shuts off at a certain voltage, but it's just going to take a lot longer. So that's why the QRS kind of just prolongs. It's not, the same amount of sodium moves into the cell, it's just at a different rate. And so it slows down. So what we're doing with bicarbonate is two different things. One is we're giving sodium. So sodium bicarbonate is a hypertonic sodium bicarbonate solution. So there's a lot more sodium, concentrated sodium in a ampule of bicarbonate than there is in normal saline or in your plasma. So though we never check sodium after giving someone 2 or 3 boluses of bicarb, if we did, we would see very transiently it would go up. Now, once it dilutes with the rest of the body, your total sodium content doesn't go up. But if you can imagine, if you're giving 2 or 3 amps in the antecubital vein, that your heart is seeing an incredibly high concentration of sodium for a brief period of time. And that's the reason why you push your bicarb and you look up at the EKG and it narrows very quickly, because I have no idea what the sodium concentration in the heart is at that moment, but it's really, really high. And so you narrow the QRS that way. We will see an increase in sodium, but it's just proportionally not that much. And the second reason we give bicarbonate is to change the pH, right? So, and this is very specific to tricyclic antidepressants. They have a pKa that's pretty close to physiologic, so that a small manipulation in their pH will determine whether the amitriptyline has a hydrogen ion on it or off of it. And it turns out that when the pH drops, the amitriptyline will bind, or any of the TCAs will bind to the sodium channels better than at a higher pH. So we're manipulating the molecule itself so that it doesn't attach to the sodium channel as well. So you're trying to increase that pH, get it up to 7.5 or 7.55. And that is usually, while that happens with the bolus, that's usually the infusion part of it. Now, I know we've talked about this before, but there isn't much evidence that doing pH manipulation for any other drug besides TCAs is effective. So I don't know. Diphenhydramine, I don't know. Propranolol, I don't know. So I do know that giving them lots of sodium does work. So a sodium bolus, a bicarb bolus will always be effective. Well, except for bupropion, that's coming up there. All right. So the one thing I think that you're probably all aware of, but it's worth mentioning again, is the very, very rapid decompensation in tricyclic antidepressant overdoses. Because of this pH issue, there is a scenario where they're wide awake and talking to you. They very quickly start to feel funny. They have a seizure, and then while they're having a seizure, they have ventricular arrhythmias. And the reason for that is that because during the seizure, their pH drops. When their pH drops, the tricyclic can bind to the sodium channel more avidly. It then widens the QRS, which either is, poor electrical conduction or leads that triggers ventricular arrhythmia. So, I typically recommend, if someone has a seizure or if you're intubating the patient, 2 amps of bicarb as soon as you can. And then one thing, as I mentioned before, the boluses are used to treat the QRS widening. The infusions are really trying to prevent the QRS from widening more, although they do actually decrease it, but it takes a very, very long time. All right. Moving from, I think that the good thing is the TCAs are like the really, really scary ones for me. And then the rest of them it's like TCA light. It's like we start taking off. We start taking off toxicities. Yes, Amy, you had questions. Yeah. Is there ever a contraindication to sodium bicarb? Um, I mean, sure, if someone if someone had hypernatremia, or if someone had a pH of 7.7, I cannot fathom how either of those would happen during an overdose or toxicity. So I am trying to think of a single, yeah, I can't think of a contraindication to an amp or two in an adult. Sure, there's like people with severe CHF may not be able to handle the sodium load and things like that. But in the heat of battle, I can't think of a single contraindication to giving someone 1 or 2 amps. Yes, an infusion that could be problematic for some people, and 10 amps, sure, I would. And yeah, well, during the seizure, you're not breathing, or at least not breathing effectively, because oftentimes your intercostal muscles are also flexing, but you are also generating, you're burning ATP and generating acid that isn't being adequately buffered. And so, we don't do this, but if we were to take a VBG while someone was seizing, it tends to be pretty scary. It's kind of like taking a VBG while you're intubating someone. They get like 7.0, like these really, really scary pHs. And we don't tend to do that because it doesn't really matter, but I think in this case it does. Yeah, and totally a renal failure patient, any more fluid you give them is going to be problematic. My recommendation is, if then we can try to come up with some complicated regimen. But if you can always give 1 or 2 amps of bicarb. That's not going to throw them over the edge, and we can always dialyze them. All right, so SSRIs, SNRIs, CNS sedation, seizures, particularly with the SNRIs, although you can get seizures from SSRIs because of serotonin toxicity sometimes leads to seizures. And then particularly I put DES, but really it's venlafaxine is the bad player here for QRS prolongation and hypotension. Desvenlafaxine is much less so, but it certainly does. This is sort of all of the, we had our TCAs, and then we have our classic SSRIs. And within the world of SSRIs, as I said before, any seizures are always a possibility, but pretty rare with the serotonergic, with the SSRIs, except for citalopram and escitalopram. I would consider those to be the ones that have a much higher rate of seizures, particularly. And then you see the atypicals down here, a couple of players. I think venlafaxine is the one that I think about when I think about things like unusual stuff like QRS prolongation and seizures. And then, higher rates of seizures with some of these atypicals like venlafaxine and bupropion, but it's pretty straightforward. So let's talk a little bit about serotonin toxicity, because I think this is probably the appropriate point in the review. So serotonin toxicity should really be, so you can call it serotonin syndrome, you can call it serotonin toxicity. The argument for serotonin toxicity is it includes a bigger, broader range, and it's not a defined thing. And this is sort of, if you start as SSRI, all of the symptoms, you get like tremulous and akathisia, and you feel antsy and anxious. And that's a serotonin effect. That's serotonin toxicity. It's just really mild. But as you increase the dose, as you increase the toxicity, you get to tremor, altered mental status, inducible clonus, sustained clonus, and then hypertonicity and hyperthermia, and obviously the worse getting more to the right. This kind of famous picture from New England Journal, trying to capture all of the symptoms of serotonin toxicity in one picture, which is not an easy thing to do, but they do an okay job. Mydriasis, sweating, tachycardia, clonus, and hyperreflexia, and particularly one of the key diagnostic factors is that the inducible clonus and hyperreflexia are much worse in the lower extremities than they are in the upper extremities. And we have certainly had people with sustained lower extremity clonus and hypertonicity with completely normal upper extremities. So that might be another one of the diagnostic clues that they throw at you. What can cause serotonin toxicity? Well, it's just a nice short, quick list. Obviously, the SSRIs and anything with a selective serotonin reuptake is going to do it. But there's a couple of unusual ones in here that we should probably just remember. Tramadol, fentanyl, and meperidine. I know that not many people using meperidine anymore, but certainly fentanyl and tramadol are still used pretty often. The anti-migraine medications. There's a couple of weird ones, like linezolid is an antibiotic that's usually used it's more of a critical care med usually, and is a monoamine oxidase inhibitor, so it leads to serotonin toxicity. Couple of other things that I think are worthy of remembering. St. John's wort, also a monoamine oxidase inhibitor, also can lead to serotonin toxicity. Lithium, and then let's see if there's any others that are on this list. That the only other one I will mention is a little controversial. I think clinically it's important, but I don't think they can ask you a question on a test about it, is bupropion. There's certainly serotonergic features to its toxicity, but it has yet to be proven that it increases serotonin concentrations significantly in the brain. And so there's some debate whether it's called serotonin toxicity. So I don't think they can ask you that question. All right, this is the Hunter criteria. This is one of the many ways of looking at the Hunter criteria, I should say. And it essentially kind of goes through all of the major symptoms. So if you have spontaneous clonus, and in order to get into this list, you have to have taken a serotonergically active drug. So you take an overdose of an SSRI or an SNRI. You have spontaneous clonus, you have serotonin toxicity. Spontaneous meaning no one had to touch them. They just shifted their weight and now they get clonus in their lower extremity. Inducible clonus means you tap on their knee or you flex their foot and they get clonus. And usually it's more than 8 beats of clonus, and oftentimes it will be 30 seconds or more. And if you have that with any of the other signs like agitation or sweating, ocular clonus is an important sign because it's certainly not pathognomonic for serotonin toxicity, but it is very, very specific for it when in an overdose. Ocular clonus, this is different from nystagmus. Ocular clonus is that both of the eyes are going in the same directions, but it's not nystagmus because there's not a fast and a slow component. Nystagmus is like there's a fast and then there's a slow, and it's fast. Ocular clonus is multi-directional and symmetrical. So it would be like their eyes would be looking straight and they would go. So it's all over the place, but they're going the same, both of the eyes are going in the same direction. So, and then the rest I won't go over because it's all sort of predictable stuff. So a couple of keys, because you might get some cases, I suspect, because I think the hyperthermic syndromes are a great thing to test people on. These are the 4 big hyperthermic syndromes: serotonin, antimuscarinic, neuroleptic, malignant, and malignant hyperthermia. So some of the keys, so we already said, tachycardia, hypertension, clonus, sweating, mydriasis. This is all serotonin toxicity. If you, they're classically their bowel sounds are described as hyperactive, but they've been everything for me, so I wouldn't get too excited about that one. Clonus is typical in the lower extremities. I think the key to this diagnosis from a test taking standpoint is its onset. Serotonin syndrome, serotonin toxicity occurs within hours. So you take your SSRI overdose and 3 hours later you have serotonin toxicity. That is very different from neuroleptic malignant syndrome. This chart says 1 to 3 days. I would consider NMS to be more of a 5 to 7 day onset. It's usually very, very slow onset. So you can usually figure this out by history. And then malignant hyperthermia is a response to either paralytic drugs or usually drugs that you're going to get during, in the operating room. So that is also very rapid onset, but you're usually getting them either right after, inhaled anesthesia or succinylcholine. And so I think that's the key, probably the biggest difference. Most of you, they should be able to give you enough to figure out anticholinergic syndrome versus serotonin. They're both very rapid in onset, but neuroleptic will be days, will be going on for days as opposed to serotonin toxicity, which occurs very quickly. All right, so I think the key to serotonin toxicity is supportive care and then benzodiazepines. That's probably the thing that are going to solve most of these problems. I don't know if they, tests tend to concentrate very much on cyproheptadine. So, obviously serotonin antagonists like cyproheptadine are a possibility and certainly can be tried. The effectiveness is, seems to be a little bit debated. It's okay. We usually use them only for mild or moderate serotonin toxicity, not for the really severe ones, because we've tried and it doesn't really work. And to give enough, you have to make them antimuscarinic, which isn't really very helpful. But there are some other, just so for information's sake, there are some other serotonin antagonists that I don't think you'll get tested on, but some have used for serotonin toxicity, like olanzapine, thorazine, and risperidone. But I don't think that'll make it onto a test. All right, bupropion. I think if you're not familiar with bupropion yet, it seems to be like the most common overdose that we get these days. It's incredibly commonly prescribed. It does increase norepinephrine, and so leads to tachycardia and seizures, also QRS prolongation, and as you all know, may be delayed with XL and SR formulations. And this is its structure. It is a cathinone. This is cathinone. It is a cathinone. And so it acts like a stimulant. So it's not really very surprising what it does in overdose. So, some of these cases have been really, really severe. Certainly activated charcoal. Would I consider gastric lavage? Yeah, I would. It would have to be a really, really big overdose with a very, very high chance that they're going to do very poorly. And then whole bowel irrigation would be a reasonable thing to do if it's an XL and SR formulation. Feels like everything's an XL or SR formulation these days, because why would you want to take your medication several times a day when you can just take it one time a day? So I just don't think they're being prescribed. So the one thing that's probably potentially a test question on this is QRS prolongation has a special mechanism. It is an alteration of gap junctions, not sodium channel blockade. So theoretically would not respond to sodium bicarbonate. Clinically, what we've been doing is give it a try, because as we were saying before, there's really very little downside to giving an amp or two of sodium bicarbonate, but don't expect it to work. So I think that's the key. If you did get a question about bupropion QRS prolongation, I think the answer is that sodium bicarbonate doesn't work. I think clinically we just give it a shot and see if it happens. And then, of course, don't forget IV lipid emulsion. There's some data on this that it is effective. And then ECMO, we've had several patients on ECMO for bupropion in the past. So let me just talk quickly about ECMO, because I don't think we're going to talk about it elsewhere in the review. So this is sort of the classic ECMO, where there's catheter in the femoral area that's carrying blood through a pump that then carries it through an oxygenator that then carries it back into right above the heart. And so what you are doing is providing both the pump and the oxygen. So you're kind of replacing both the heart and the lungs. This is VA ECMO. There is another, one catheter that goes in the neck that pulls blood from the IVC and then supplies it back to the right atrium, but that is really just a matter of the equipment, so that's not all that important. The ECMO machines are now, all of this stuff over here that are pictured is all really compact now. This is the whole ECMO machine nowadays. So if you haven't seen one, they're pretty amazing, honestly. And as I said before, we've had several people on ECMO for bupropion. So I expect to see this more often. All right, so a couple more. I think we have lithium and monoamine oxidase inhibitors. So lithium therapeutic concentrations roughly 0.5 to 1.2 or so. Loading, you can do a little bit of prediction of how high the lithium concentration will be, because there used to be, they don't do this anymore, but it used to be that you'd give someone 40 milligrams per kilo to get them right up to the top of therapeutic. Sort of back in the day, people don't do this anymore. They just start with a regular dose and they titrate up or down. But the obviously early on for a truly acute overdose, which we almost never see. I think we had one maybe a month or two ago. This is someone who does not take lithium, who then overdoses on lithium. They're relatively asymptomatic very early on with a very high lithium concentration. And then 4 to 6 hours later, it slowly distributes. So you get this very high serum concentration and then no symptoms. And then 4 to 6 hours later, now they have symptoms and their lithium concentration is much lower. The symptoms are usually this sort of, it's not really CNS depression. They're like wide awake, but they have very, very difficult time processing and responding. So they're very slow to respond, very confused, and they will often get hyperreflexic and tremulous. So again, super rare, less than 1% of our lithium cases are people who overdose acutely. And we would consider early hemodialysis if the lithium is greater than 5. Again, we're talking about someone who is asymptomatic with a lithium over 5. And if they had renal failure, then if it's over 4. There is some consideration of whole bowel irrigation. We usually don't, because they're not truly a ghost pill. They're not something that I think will actually benefit. And of course, activated charcoal is not particularly effective. But we can give K-exolate, and I think this would be an acute overdose where there's lots of pills sitting in the stomach is the ideal situation for K-exolate. It's, I think, much less effective when the lithium is already absorbed. So if someone just took their overdose recently, filling their stomach with K-exolate to exchange right there in the stomach before they absorb it seems like a really good idea. If they're already late in their course, I would still do it because it can be effective, but it's just less effective. All right, the common thing we see is chronic toxicity. usually caused by therapeutic dosing with a decrease in renal function. So this is the person who gets a GI disorder, or they get dehydration for some other reason, or they get started on a diuretic or NSAID. They come in sort of maximally symptomatic, hyperreflexia, hypertonicity, tremor, sedation, usually a high B1 and creatinine. They have a whole series of very non-specific EKG changes, which I don't think really have much in the way of significance, but ST depressions, T wave inversions, T wave flattening, all of these things resolve when the lithium goes away. I don't think they're clinically relevant, but you may hear about them and people may get very excited because they're getting serial troponins because of the ST depression, which is totally appropriate, and they should continue to get their troponins. But it's probably a lithium effect. And then the one thing I would say, the cardiovascular one that's been described a bunch is bradycardia. We don't really see it very much. And all the cases I have heard of or seen have been like 50s, not really anything that's really scary. So remember that lithium concentration, if it's chronic, doesn't have to be particularly high. It can be 2 and they can have symptoms, or even 1.8 or something like that. And those, because the distribution is slow to go in the brain, it's also slow to go out of the brain. And so these CNS symptoms may last for quite a long time. Remember that green top tubes, and I forgot, somebody reminded me of this recently, and I just added it to the guideline again, that if you draw the blood in a green top tube, that is lithium heparin tube. It has lithium in it. That that little thing of fluid at the bottom is lithium. And so if you fill the tube, you can have a false elevation of your lithium. It's not really a false elevation because it is lithium, but a contaminated sample, I suppose, up to about 1 or 2. So let's just say your lithium is 1, it may come back as 2.2. If you don't fill the tube, if you have like a half filled tube, it can be up to 2 or 3. It's milliequivalents per liter. So you could have a 0 lithium, but it says it's 3.2 or something like that. So it can be a really, really significant increase if that tube is green and the tube isn't filled. Should we give, oh, I see. Yeah, I think so. I'll have to take a look at our, do we have a guideline? Yeah, we do. I'll have to take a look at what it says, because I would think if someone had an acute, and remember, this is like certainly less than 5% of all of our cases, but probably less than 1%. Someone has, or acute on chronic, and then we know they have lithium in their stomach. I think it's pretty reasonable to give them Kxalate. I think I would want to see a potassium first. I would hate to be wrong. It turns out they didn't take lithium, they took something else, and their K is 2.2, and now it's 1.8, and it's, we did that to them. So I don't think it's a super emergency. I think my concept with Kxalate is it works as an exchanger when the lithium's in the blood, but it works even better when there's lithium in the stomach, because you're just mixing Kxalate with lithium, and you're gonna trade sodium for lithium for all of that. So you're basically loading up the Kxalate with lithium as best you can. So I think that's a much better scenario than the 12 hours later. Okay, so treatment is rehydrate them, because once you get the kidneys working, they will clear the lithium. It's just going to take a long time, unfortunately. So hemodialysis is can be indicated. The XTRIP guidelines use relatively high numbers, so greater than 5 if there's normal kidney function, greater than 4 if there's abnormal kidneys. Usually there's abnormal kidney function because of the dehydration. But they also say if you're significantly symptomatic, then you should get treated. So all of these people have significant symptoms. And they also make this odd recommendation that if we expect the lithium to still be over 36 hours from after the overdose, then you should do hemodialysis. So I don't know how to predict that. It's not easy. But I think that CRRT is going to be a really, really good answer for this. In lieu of, for example, transferring someone, 150 miles to get hemodialysis, having them stay in a hospital in Southern Oregon and getting CRRT, continuous renal replacement therapy, I think would be yeah, I think that's going to be a better solution as we go forward. There's still criteria for hemodialysis. So I would say at this point, if they meet criteria for hemodialysis, obviously on your test, they get hemodialysis because everything works functionally. But I think there's a going forward, there's going to be a good push towards CRRT. So there is a paper out there predicting what concentration of lithium with chronic toxicity will still have a concentration over 1 at 36 hours. And it ended up, if I recall correctly, being something like a lithium of 2.2 or higher. So essentially it says we should dialyze everybody. Yeah, like with that. So, if you have altered mental status or you have a lithium over 2, we should dialyze you, I guess. So this is why I think CRRT is going to have a much bigger role going forward. So a couple of rare things from lithium that we should, I think could definitely be questions. Lithium can cause nephrogenic diabetes insipidus, which results in very, very high volume dilute urine. Because you're losing all of that water, you end up getting hypernatremia, and this can last for days. The treatment is just replacing the urine loss. So what you usually do is you do sodium testing on the urine and take the volume of urine produced over the last 24 hours, and you replace that amount of fluid and sodium in using IV fluids or, like free water. So low tech solution, but that is usually what they usually do, and then it gets better once the lithium concentration goes down. So yeah, exactly. So it does. So what they usually do is, because the urine is super dilute, they usually do start with something like D5W. But then you would just measure, you'd say, oh, this person made, over the last 3 hours, they produced 8 liters of a fluid that had a sodium of 5 milliequivalents per liter. And so you would give them, this is why neurologists get paid. You give them like that amount of normal sodium plus free water, usually. And if the free water is too much to drink, then they would just give D5W. So these get super complicated, but it all depends on what the sodium concentration and what the volume of fluid that you're putting out is. And you can give, yes, exactly. And you can give DDAVP. That's not going to be any of our call. That's going to be probably the nephrologist's call. And the other thing that comes up with lithium is the syndrome of irreversible lithium effectuated neurotype. If someone really, really, really wanted a cool acronym. But really what this means is people who have neurologic abnormalities from lithium that don't recover. It is very controversial. I don't think there'll be questions on it because it's very confusing and nobody really understands it. I think it's important to recognize that some of the people who get lithium toxicity stay neurologically, affected. And those symptoms are often ataxia and cerebellar symptoms, but it's really, really, there's no way to predict it. Dialysis, in fact, doesn't it doesn't decrease their risk as far as we can tell. In fact, it may even increase their risk. So, I kind of throw up my hands at this, but I think it's important to recognize that some people, unlike almost all of the things that we take care of, some of these people will continue to be affected. All right, last one is monoamine oxidase inhibitors. They're incredibly unusual to come across these days. I always feel like they're making a comeback and then they don't. So mostly because of the significant side effects. So monoamine oxidase metabolizes catecholamine. So if you inhibit it, then you end up with catecholamine toxicity or stimulant toxicity, if you will. There are some other reactions. There's this sympathomimetic type reaction called tyramine reactions from tyramine that then can't be degraded because of the inhibition of monoamine oxidase. And tyramine is found in large quantities in things that are fermented. So beer, sausage, and then also alcoholic products that are obviously also fermented: wine, beer, cheese, yeast. I'm sure kombucha, although I don't know for sure. And this can lead to a hypertensive emergency, which is the main thing. But they look like a stimulant overdose. The response to it is vasodilation. The treatment is going to be vasodilation. It's classically been phentolamine, which is an alpha antagonist that causes vasodilation. Nobody uses phentolamine anymore. So I think that most people would treat with nicardipine because it's a commonly used vasodilator. That's a calcium channel blocker. But I think that one of the important things is for tyramine reaction or for monoamine oxidase inhibitor overdose is to avoid beta blockers. And it's simply because of the concern about unopposed alpha effects. Unopposed alpha has been really well, I shouldn't say that. It has been described in a certain subset of people who use cocaine. But not really with amphetamines. So I'm not sure this is actually a problem, but I think on an exam, beta blockers are contraindicated. Unopposed alpha means that, you've got this tyramine that's stimulating alpha and beta, both of them, and then you block the beta. And so you have this unopposed alpha effect, which is vasoconstriction, and it can lead to hypertensive emergency or vasospasm. It was described in a group of people many, many years ago, apparently before IRBs existed, because they took a bunch of people to the cath lab for their coronary artery disease, and then they consented them to get some cocaine before their cath. They gave them intranasal cocaine, and then they gave them beta blocker, and they watched their coronary arteries spasm a little bit. The effect wasn't huge, but it doesn't have to be huge to, if you're decreasing your blood flow to your heart. So that has never been described with tyramine reactions, but it's obviously a concern, and we don't want to hurt our patients. All right. So the other thing with monoamine oxidase inhibitors, because it inhibits the degradation of serotonin, it can also lead to serotonin toxicity. And there's one odd thing about overdose is that it's fairly delayed. And I chalk it up to, and maybe this is just, a simple brain trying to make sense of a pattern, but I chalk it up to it's an indirect acting agent. So it inhibits monoamine oxidase, which makes you stop degrading catecholamines, which have to accumulate. And so the catecholamines have to accumulate over, say, 6 or 12 hours. And so monoamine oxidase inhibitors are, there's been several cases described where the person took the overdose, was asymptomatic, watched for 4 hours, sent home, and then, they end up back in the ER at 9 hours or so with a hypertensive emergency. So these are admit for 12-hour minimum for observation for that. All right. Well, that took me a bit longer than I expected, but that is okay. As I said before, we can flex up and flex down. Do you guys want, it's almost at the hour. Let's take a couple minute break. I think we take a break every hour. I think that's a good pattern to stay in. All right. If we can make it relatively short, just like 3-4 minutes, and then come back, and I'll try to catch up on time. Thanks.